Well, hi, everybody. My name's Chad Cook, and it's time for another Shop Talk. And as a reminder, at Shop Talk, what we do is we take a look at articles that were published by authors. We bring them on. They tell the story behind the paper and what they found. And today, our guest is Dr. Robert Trager, and he's the author of a recently published paper in Chiropractic and Manual Therapies. And the title of the paper is Clinician Approaches to Spinal Manipulation for Persistent Spinal Pain After Lumbar Surgery, a Systematic Review and Meta-Analysis. And for all of those that are going to be wondering, it is available open access, which we always appreciate. First of all, Rob, I changed times on you so many times, and I appreciate your flexibility, your accommodation on this. Today is Juneteenth. Yesterday was Father's Day, so you squeezed us in. So welcome.
Thank you so much for having me on. It's really a pleasure to be here.
So I'd love to hear your background, what you're doing right now on your day-to-day job, but also your research background. Do you mind filling us in?
Absolutely. So I am a chiropractic physician at University Hospitals, Connor Whole Health in Cleveland, Ohio. And that occupies most of my working hours of the week. And part-time, I'm also doing research. Since basically a couple of years ago, I'm still relatively early on in my research career, and I'm learning as I go. And I started off with things like case reports and worked my way up into review papers. And now we are conducting some observational studies as well. And so it's been a great transition and a lot of fun. I've been in practice for 10 years now. And it's great to be in an integrative setting as well, working with physical therapists and medical providers, really getting to collaborate on the care. And that also works its way into the research model as well, just brainstorming ideas and trying to come together on these multidisciplinary teams to get better insights on our research questions and reduce bias as much as we can.
So tell me about your day-to-day. I mean, I'm intrigued about the multidisciplinary efforts that you get to work with. So what's a typical day look like for you?
Well, there are two offices that I work at affiliated with the hospital, and they're very different. One of them is an outpatient office setting that is a lot of healthier individuals, let's say. And then the other office setting that I work in is more chronic pain, and it's attached to a hospital, community hospital. And we get a lot of referrals from pain management and a lot of patients that have had spine surgery in the past. And that's what got me thinking in terms of doing a study like this that we did, focusing on treatment with spinal manipulation after spine surgery, because this is just something that's extremely common that we're seeing in the office. And we don't have a great idea as to how to manage that. And then one day a week, I'll be doing research all day. And then the other days, I just do little bits and pieces, whatever I have time for.
So you are seeing a lot of patients that have had spine surgery before. And, as a chiropractic physician, is this a population that you use manipulative therapy with, or what's your strategy with these individuals?
Yeah, the strategy is really patient dependent. I do use spinal manipulative therapy, and I will tailor that to the patient presentation. And that goes basically beyond the review that we did. I mean, we didn't find out, not to give away all the results right away, but we didn't find out what should we be doing. We're just finding out what people are doing. And what I do is basically I look at it as a combination of what the research is suggesting and what the patient is comfortable with and what my experiences are, really that threefold approach with evidence-based medicine in general, just trying to rely on all the different data sources or inputs that we can to guide us as clinicians. And it's very complicated. I mean, coming out of chiropractic school, there was not a lot of information on this and what should we be doing. Of course, we learned about things like adjacent segment disease and things like that, where you can have issues next level to a spinal fusion, for example, or degenerative changes next to a fused joint. But beyond that, I mean, it's not really well known, and it still isn't well known. I mean, as 10 years have gone by in practice, we haven't learned that much about this. So that's what I thought there was a big gap in the literature, and we needed to start to fill that.
I agree. And first of all, very necessary, very timely. I remember in the early 90s when I practiced as a physical therapist, I would get questions from patients. I would get questions from physicians on whether or not it's okay to use manual therapy post spinal surgery. And I didn't know how to answer that. In your paper, you actually indicate that 20 to 40% of individuals will have ongoing spinal problems after surgery. And this is a massive population. Is I mean, is it your clinical experience and just the sheer numbers alone? Is that what drove you to really look at this paper? What was the nexus behind this paper? What was the reasoning behind it?
Yeah, I think you're right. It's highly prevalent amongst patients that have had spine surgery, and that can be for several different reasons, such as just simply symptoms that were there before just come back over time. I mean, there can be degenerative conditions that are recurring basically regardless. It's not necessarily anyone's fault. It could be time. I mean, of course, things can go awry with the surgery. I mean, there's predisposing factors, and these are patients that are in a lot of pain. They have a high use of medical and non-pharmacological treatments. It's affects quality of life. I mean, these people need some kind of help, and they're just trying to get relief. And as a provider of conservative care, I mean, there's a question, can what we do help? And like you said, I mean, there's maybe not a lot of knowledge if it's useful or not. And I've heard different opinions on this, and even from one extreme to the next. I mean, you might hear some people say, don't let, such and such happen, or don't let anyone touch you, or whatever. And that's kind of the far extreme of don't do anything like manual therapy. And then the other extreme, we have people doing a lot of hands-on treatments. So it still remains to be determined, what's the most appropriate. There's no consensus on it, but the fact remains that there are a lot of patients. There are thousands of patients with this that have persistent or recurrent pain after spine surgery. And it's probably a growing number with the aging population and as more and more people have surgeries.
I think you mentioned in your paper that over half of chiropractors have indicated that they view past surgery as a contraindication and they don't actually use manipulative therapy based on that. Did I read that correctly?
That's a good point. And one of our co-authors, or the second author, Dr. Daniels, ran a survey with the Veterans Health Administration chiropractors. And that particular statement comes from a question he asked about spinal fusion, lumbar fusion, and very few chiropractors were doing thrust manipulation for patients who had a spinal fusion. And that really fed into our study. And the other data point we have on that was a panel of basically experts that rated whether or not spinal manipulation was appropriate for patients with laminectomy. And there was a relatively high consensus that it was appropriate, thrust manipulation or mobilizations without a thrust. And so we have these two extremes. We had one study saying very few people are going to do any kind of thrust manipulation on a patient with a lumbar fusion, and that was chiropractic study. And another, on the other extreme, we had people saying, okay, go for it, do spinal manipulation if there's a laminectomy. And so that really made a light bulb go off in my head, and thinking, well, maybe it's the type of surgery that matters. Maybe if clinicians are saying there's a fusion, they don't want to manipulate, and the opposite, laminectomy is a very minimally invasive surgery, just removing some bone. There's no hardware implanted. It's a total opposite. So maybe that would explain why. And that's what drove some of our hypothesis in the study and the impetus as to why we did it. And maybe there's some sort of differing characteristics with the surgery or the patients that dictates how the clinicians approach these patients.
Yeah, and to my knowledge, that wasn't the real driver behind the use, right? I mean, I think you astutely mentioned that the severity of the surgery or the complexity of the surgery would probably be a driver. But what did you find as the drivers for use in? Tell us about your findings.
Yeah, so In our study, we hypothesized, just to reiterate, basically, was it dependent on how complex the surgery was and how complex the patient presentation was? We felt that the more complex the situation was clinically or surgically, the more gentle the spinal manipulative approaches would be. And so just to kind of go through our findings, we found about 70 articles, most of which were case reports, and we had over 100 patients that were in those studies. And these were basically case reports in series from all over the world. We had chiropractors, traditional East Asian medicine providers, physical therapists, and MD, DO, medical providers, and they're all using different spinal manipulative techniques with these patients with persistent spinal pain after low back surgery. And we categorized the patients according to several different variables. I mean, whether or not the pain was radiating down, whether or not there was an implant in the spine, was there a reduction in the number of movable joints in the spine? Basically, was there a fusion? And, you know, who's the treating provider type? I mean, all these different types of things. How long had it been since surgery? And how old is the patient? I mean, it goes on and on. I think we had 13 different items that we extracted, and about 10 of those were related to the clinical surgical complexity. And after that, we did basically just a descriptive analysis. And we found that the most common techniques that the providers were doing were non-thrust manipulation. So there's a difference. So thrust manipulation, there's an impulse. It's typically a little more forceful, although the force can vary quite a bit. And then you have mobilization where there's no thrust, and it's typically gentler. I know it's hard to describe the two just in terms of force, but in practice, one is typically gentler and one is a little more aggressive. And so what we found was the majority of clinicians were using non-thrust manipulation with patients who had previous back surgery. And in particular, something called flexion distraction, and we can get into that too. And less practitioners were using thrust manipulation. And
Do you mind?
yeah.
I'm sorry. Do you mind describing flexion distraction?
Yeah, for sure. Flexion distraction, it is a non-thrust manipulative technique where a patient is typically lying prone on a table with a special hinge, basically at the lumbosacral junction or the lower back. And the table can flex and extend basically up and down at that segment. And it doesn't really go up that high. It goes up to about neutral or a little higher and then can flex down. So as it flexes down, the clinician is providing a contact, just maintaining a hold position on the patient's lower back or just above the lower back, depending on what's wrong. But that creates somewhat of a distraction or attraction force on the lower back. And there's also a little bit of a mobilization component with that as well. And so that was an extremely popular technique. We saw clinicians using that in traditional East Asian medicine case reports, chiropractic case reports, all over the world. I mean, from different authors. It was pretty interesting how that was so common. And it's not like there's research, high level clinical trials or anything showing that that's effective. It just seems like clinicians gravitated towards that, perhaps out of a notion to maybe be more gentle with the patients is what we thought. But in terms of our logistic regression model, we ran a model to determine whether or not any of these clinical or surgical factors were independently predictive of a certain approach and technique. And by and large, we found that they were not really independently associated with the techniques. We did find that chiropractors were more likely to use thrust manipulation. And that was one finding. And it's not too surprising, but because chiropractors typically use thrust manipulation more than other providers, regardless of what's going on. So that was not too shocking. But the one thing that was almost confirming our hypothesis was that patients that had reduced motion segments in the lower back were less likely to get thrust manipulation. So if you have a fusion, you're probably not getting a thrust manipulation. We had a p-value of 0.05 there, so it just barely did not reach statistical significance. But for all intents and purposes, we can pretty comfortably suspect that if you have a fusion, you're probably not getting a thrust manipulation. And And just to boil down the overall interpretation I have of this is, what is the standard of practice? What is the standard of care? What is being done out there in the real world? And we're seeing some trends, if you will, as to what is happening. We have providers using gentler techniques in these patients with spine surgery, flexion distraction, and maybe they're avoiding thrust altogether, thrust manipulation altogether, especially if there's a fusion. And of course, it's pretty early on. We're the first sort of study to look at this at all, but I think it lays the foundation for future research. And if you wanted to, for example, design a study or a randomized controlled trial or an observational study that's larger powered and try to get into the effectiveness or the efficacy of these treatments with respect to reducing pain or disability or improving quality of life, we have to come up with some kind of selection criteria. So what are the inclusion criteria? What are the exclusion criteria? And so based on our finding, we know the mean age of these patients. We know that they're typically middle-aged to older adults. We know what surgeries they have. I mean, it's a good blend of discectomy, laminectomy, fusion. But we also know what the treatments they're getting are with spinal manipulation. We know that, if you were to design a study like that, you'd probably have a trial focused on adults with either a fusion discectomy or laminectomy. That doesn't really matter so much. And you'd probably set them up with a non-thrust manipulation just to see how effective that is. And so we kind of, I think, help lay the framework for future research on this and as far as outcome studies.
Let's take a step back. You had 71 studies that, in fact, you may win the award for the longest table one I've ever seen in a paper. It actually covered 3 pages. And I was stunned that there are, even just being case reports or case series, I was stunned that there were 71 studies that actually looked at this. Was this a surprise of yours when you dug into that?
Fortunately, our second author, Dr. Daniels, did a systematic review on this a year or two beforehand. And it was a broader topic. It was looking at any manual therapies. But from that, we were able to discern that there was not a lot of literature on this topic. And knowing that in advance and doing a bunch of test searches, we decided to include gray literature. And that is what really bumped up the number of articles that we had. If we didn't include gray literature, we would have had something like half the number of studies. I think half of our studies were from gray literature. And so that includes things like theses. We had a couple of conference abstracts that we pulled in, and just all kinds of things. I mean, we use the index to chiropractic literature, which includes a lot of this manual therapy gray literature, which is great. And our strategy included reaching out to the study authors to get additional information, and that was successful in a few cases, which really, really helped us out because the literature is very sparse on this, but somehow we were able to get 71 papers. And then that included actually a couple cases that appeared in a textbook as well. So we were searching far and wide on this. I mean, we really scrapped together pretty much everything that we could possibly find.
Can you give the listeners an estimate of how much time goes into one of these? Because you do a really nice job in the paper of describing all the different avenues that you went through and actually pulling this information, including reaching out to authors, but even your data extraction methods were very comprehensive. Can you give those who have never done a systematic review, especially one this comprehensive, can you give them a time estimate on how much work is involved?
Yeah, I would say it seemed a lot simpler when we came up with the idea, and it just wound up taking a really long time in practice. But we spaced it out on purpose. We knew that it was kind of a complicated and unusual design for a systematic review to include so much gray literature, to include case reports. And early on, we had some people kind of asking, well, like, why are we doing this? Why are we looking at case reports? And I love case reports. I mean, but when the literature is so limited on a topic, you have to, because that's all there is. And if we did randomized controlled trials, we might have one study. So it wouldn't inform anything. So I think when you have a topic that has limited investigation and you're doing all of your test searches on whatever database you want to do. I like Google Scholar before I even get into the actual databases like PubMed and things like that, just to poke around and see what's there, and then come up with a really rigorous protocol, register it, get together, a multidisciplinary team actually before you register it. And we work with a research librarian who helped us put together a really awesome search string, and we tested that and we modified it. I mean, that whole process, I think, took a year, and then we published the protocol. And then there was a bit of a gap in between that and when we started on this, because, I mean, once you establish a solid protocol, you get some good peer review on that. You maybe modified a little bit. We updated our Prospero registration. I mean, you can't just go rushing into something like this, because I think at the end you'll realize maybe you missed some important studies, or you have to tweak things. And we actually had a hypothesis too. So we didn't want to just start changing things around when we were close to wrapping up. We really wanted to have a good idea of what we're doing. And yeah, the whole thing took at least 2 years.
Wow. So, Rob, this is a out of left field question, but how have your findings, how has this study changed your approach to clinical practice?
I would say that it has given me more comfort and confidence in what I'm doing, because I use a lot of mobilizations on patients with previous lumbar spine surgery out of precaution or concern that I could exacerbate some pain. I mean, these are patients that maybe have residual nerve damage from before the surgery. They might have ongoing degenerative disc changes that are relatively significant, maybe radiculopathy. They may have sensitization and their pain thresholds are very low. We don't want to flare up their symptoms, and we don't want to hurt them. We don't want to aggravate or exacerbate anything going on inside the spine. And a lot of times you can get relief with mobilization, and you can really help people out. And so it doesn't always have to be a thrust manipulation to help the patient the most. And then one of your friends of the Shop Talk, Dr. Casper Nim, published a paper on the site selection of spinal manipulation, and found that it may not matter as much where exactly the manipulation is. You're still getting relief from that. So I'll use thrust manipulation in the thoracic spine or the sacroiliac joint sometimes if the patient's prone. And then a lot of times the symptoms will go away, because biomechanically, neurophysiologically, all these regions are interrelated. And if we can just reduce patients' pain levels, get them a little more active, co-manage them, maybe with physical therapy, aquatic therapy, pain management, then we don't have to completely fix them, quote unquote, by spinal manipulation. It's just part of the process. And I think it fits into the larger context of therapies that we use. I mean, I'll also use dry needling. We have an acupuncturist in our office I'll refer to, and all different things. So I think it's part of the mix. I think that as a practitioner, oftentimes you want to do as much as you can to help the patient, but sometimes I think that can backfire, and sometimes doing less is doing more. And I think that knowing that a lot of other clinicians around the world maybe have the same mindset, or at least that's what they're doing. They're not trying to overdo it with the patients. They're just mobilizing using some gentle techniques. I think it's quite appropriate. And there are limitations of our study. I mean, we don't know what's the most effective or what's the most safest, but I think there's maybe a starting point to at least say there might be some consensus on this, at least from published case reports and series.
So what's your next step? Are you going to take this work and expand it? Are you planning a comparative effectiveness trial, or what's the goal?
The goal is to not hop straight into a trial. I think that's still a little preliminary. I think we need to do some work in between. We just published a study where we looked into the percentage of chiropractic patients who had previous spine surgery. And it was something like 10, 11, 12%, depending on the year. So it's very common. I mean, at least in academic medical centers, which is where we looked at. And then the next step is to do some observational studies where you might be mimicking sort of a trial outcome. I really would like to look at some observational studies, large populations of patients that are getting spinal manipulation who have had a previous spine surgery, and what are the outcomes with that. There are some large databases that we can look at, some databases that include medical records data or administrative claims data. And we can look at different outcomes like health service utilization, which is a very, I think, very nice way to enter into this, because we can look at long-term outcomes and we don't have to spend $100,000. We don't have to spend all these resources to get it done. I think once we have an even more crystal clear idea of, is there some measure of effectiveness here, that we can use that to justify doing a trial down the road, if that makes sense.
I really like the way you think. And as a user of large data sets and one who has looked at spinal manipulation in inpatient hospital settings through the nationwide inpatient sample, I think there's a lot of value there. Like you said, you're not going to spend millions of dollars on something, and it really does help guide the approach. Rob, if you had a 1-minute elevator talk and you were at a conference and you were speaking to some junior clinicians, what would you say about the use of manual therapies for post lumbar surgery?
Yeah, I would say that we know that patients with pain after lumbar surgery are getting spinal manipulation from various provider types, people who have had various types of surgeries. We don't know how effective the treatments are, but we do have some idea of what those treatments include, and they often include mobilization techniques, which do not involve a thrust manipulation.
Very nice. If someone wanted to follow your work or get in contact with you, are you on social media? What's the best way to follow you?
Probably ResearchGate or Google Scholar are two good places to look at. I mean, we do have our hospital website has a profile for me as well. Any of those things. I mean, we're always doing research, and we're always looking to talk with interested people and reach out and just communicate with the greater community of clinicians and researchers in this field.
So you're not on social media?
I don't use like Twitter that much, although occasionally I will post one of our studies on there.
It'll just warp you anyway. So I think you're being smart. Rob, thank you so much. This is a great topic. We appreciate your work. This is exactly the type of thing that our listeners want to hear. And keep doing what you're doing. This is fantastic.
Thank you so much for having me, Chad. I really appreciate your insightful questions and all of the work that you're doing as well.
Thank you.